Fine. So on behalf of NNF Gujarat, I, Secretary Dr. Prashant Karya, welcome one and all to today's neonatal Pathshala. Rituparna, if you are able to share the screen, start your presentation. There is an issue with your voice, so leave it. I request President Dr. Dipen Patel to welcome one and all. Thank you.
Good afternoon, everyone. On behalf of Gujarat NNF, I welcome you all on this digital platform. It is privilege for us to have Dr. Fagun Sasar, who is a nephrologist in pediatrics from Surat, and we have Dr. Vishal Gohil, who is a neonatal intensivist from Ahmedabad. We have a PG case presentation by Dr. Satyendra Adav, who is from Pramukh Swami Medical College, Karamsad. So I thank you all for accepting the invitation to participate in Pathshala. I request Dr. Prashant Karya to introduce our faculties and the presenter.
Thank you so much. So on behalf of NNF Gujarat, I again welcome one and all. Today's PG case presentation will be done by Dr. Satyendra Yadav, and we do have two experts with us. Dr. Vishal Goyal, he is a consultant neurologist at Arpan Newborn Care Center, Ahmedabad, with Dr. Ashish Mehta sir, and they are managing many newborns at their centers. He has done his fellowship in neonatology from Royal College of Pediatrics, UK. His main area of interest is taking care of extreme premature. Thank you so much, Vishal bhai. We do have Dr. Fagun Shah with us. He is pediatric nephrologist from Surat, a close friend of mine, having Child's Kidney Care Center at Surat, affiliated to all the hospitals of Surat, major hospitals, and he is a faculty at various national, state, and local conferences. He was organizing secretary of West Zone Pedico in 2019, and his areas of interest are critical care nephrology and renal replacement therapy. So, welcome, Dr. Fagun. And today's presenter, Dr. Satyendra Yadav, he is a DM neonatology student, first year resident at Pramukh Swami Medical College, Baikal. So, with this brief introduction, I request Satyendra to start the presentation. I request all the participants to keep their them muted, and if they have any questions, they can just write down in chat box. Satyendra?
Sir, his screen is still frozen. We just need a minute.
Okay. So, Dr. Fagun and Dr. Vishal will just wait for him.
Shraddha.
Yes, sir.
Shraddha, tell Satyendra to send his PowerPoint to me or Dr. Prashant straight away. So we will open from our device.
Okay,
or
sir.
you can use your laptop.
Okay, sir. Okay.
So he's with you or where?
Yes, sir. He is with me.
So your laptop you can or either Bhushan's laptop he can use.
Yes, yes. That's what we are doing, sir. Just almost done.
Okay. Okay.
Sorry for the inconvenience. Satyendra has joined from the other device and is starting.
Hello, can you hear me now? Sorry.
Yes, Dr. Vishal. So by the time Satyendra is presenting, one or two announcements from NNF Gujarat. NNF Gujarat has just launched a kangaroo mother care module that is for the nurses, and that will be available on the NNF Gujarat website, and all the nursing and paramedical staffs can access it. Dr. Deepen, we are also having a Bhuj Neocon in Karamsad. So by the time Satyendra is coming, if you can just brief about the Bhuj Neocon. Thank you.
So we have so thank you, Dr. Prasad. So we are going to have a Gujarat State Chapter National Neurology Forum Bhuj Neocon conference in the 28th and 29th October of this year. So probably we are going to organize this conference at Madhuban Resort at Anand and Karamsad. Workshop will be at Karamsad and the conference will be at Madhuban Resort. So we are in short time we will announce our brochure for advertisement. So we expect a huge and great event in this year because the last 2 or 3 years have gone in COVID. So we will try our best to have best neonatology conference for this year. So we will have oral and poster presentations for postgraduates. So shortly we will announce for it. So we expect a huge participation of PGs who have done their research in neonatology. Yeah, I think Dr. Satyendra, are you ready? Are you ready to share your presentation? Satyendra?
Satyendra, reply.
Bhushan?
Satyendra, unmute. Are you ready?
Shraddha? Bhushan? Samir? We have many from the same place who have joined from different devices.
Yes, sir.
Yes, sir.
So is he ready or he can share presentation to me? I will share from my side.
So basically,
Huh?
share screen.
आप उसको पहले स्लाइड शो में कर दो और शेयर करो
Yes,
सीधा।
sir.
उसको आप स्लाइड शो में पहले करो पहले। हाँ, यस, नाउ इट इज रेडी।
आ गया ना स्क्रीन पे?
यस, आ गया।
नई वाली PPT.
Yeah, Satyendra, are you ready?
Am
now?
I audible?
Yeah, you're audible.
Good afternoon, everyone. Good afternoon, respected teachers. Sorry for some delays because my screen was hanged.
Yeah, no problem, no worries. And over to you, Dr. Vishal and Dr. Fagun sir, for the case presentation.
Yeah, you can go ahead.
Satyendra, go ahead with the case.
Sir, I am presenting a case of 20 days old female newborn of XYZ. Maturity was 39.5 and which was delivered normal vaginal delivery on 12th April 2023 and birth weight was 2.9 and informant is mother which is reliable. He referred to our baby was referred to our NICU at 2 hours of life in view of severe respiratory distress. Now, the antenatal history, mother is 28-year-old, gravida 2, para 2, live 2, G1 is female, full term, normal vaginal delivery, and birth weight was 2.4 kg, cry immediately after birth, and now she's 2.5-year-old. And pregnancy was diagnosed with urinary pregnancy test at 1.5 months of amenorrhea. LMP was LP was 5th July 2022. Expected date of delivery was 12th April 2023. Pre-pregnancy weight was 48 kg and mother blood group is A positive. Now the first trimester history, mother was a booked case at private hospital and taken regular antenatal visit at monthly interval. She tested negative for HIV, HBsAg positive, VDRL and folic acid was taken regularly. First trimester scan was normal, but the report is not available. There is no history of fever, rash, lymphadenopathy, drug and radiation exposure. Mother's HP was 10.7 gram. Now the second trimester history, quickening was felt at 5 months of amenorrhea. Both iron and calcium tablets were taken regularly along with folic acid, and first dose of TD was taken at 16 weeks of gestation and second dose of TD was taken at 24 weeks of gestation. USG scan was done at 20 weeks of gestation, which was normal. There is no history of PIH, gestational diabetes mellitus, anemia, and thyroid disorders. Now the third trimester history, antenatal visits were taken every 15 days nearby private hospital and mother's weight was 58 kg. Third trimester USG scan and Doppler was done at 36 weeks of gestation, which was normal, and estimated fetal weight was 2.958 plus minus 346 gram. There is no history of fever, burning micturition, convulsion, foul smelling discharge, leaking or bleeding per vaginum. Now the perinatal history. Mother was admitted with labor pain on 11th April night and she underwent normal vaginal delivery. A baby girl was delivered at 10 a.m. on 12th April 2023 at private hospital. Now the postnatal history. As per referral notes, baby did not cry immediately after birth. Apgar score not mentioned. Baby had thick meconium stain amniotic fluid and severe respiratory distress, and baby was intubated and referred to our hospital on bag and tube ventilation for further management. A vital parameter at admission. Hello.
We can hear you.
Am I audible, sir?
Yes, yes, you are
Yeah,
audible.
sir.
Go ahead.
Yeah. Temperature was 35.5 degrees Celsius, moderate hypothermia. Heart rate was 184 per minute. Respiratory rate on bag and tube ventilation. CRT was 2.2 seconds. SpO2 is 84% in preductal and 74% at postductal. Pulse is well palpable in all four limbs. RBS at admission 54 milligram per deciliter and BP was 68/34. Mean was 45. Now the brief.
Satendra, sorry to
Yes.
interrupt.
Yes, sir.
Yeah, so based on this addition finding, like if you see the saturation level like preductal 84% and the postductal 74%, then when you see this kind of finding, what will you think about the baby, like physically in point of the like delay transition of the fetal to neonatal circulation?
Sir, because there is difference is 10% almost significant. So there is shunting from right to left. So if there is patent ductus arteriosus and patent foramen ovum. So, and it's also signified that there is differential cyanosis.
You took very good antenatal history. Then, if you see the antenatal history, is there any point which is helpful for you to manage this baby in perspective of the PPHN?
First of all, sir, in antenatal history, if there is any history of fetal distress and maternal illness like preeclampsia, PIH, and mother illness like respiratory and cardiac illness, and there is history of maternal medication intake like NSAIDs and aspirin and SSRIs, and if
Yeah,
these are
this is
the
rightly said. Yeah, very good. This is rightly said by Satyendra that the antenatal history is really important when you manage the hypoxic baby in form of the PPHN or either other cause. Like for example, if baby has a normal anomaly scan, then it's a good thing that we rule out the congenital heart disease or like CDH. If mom has a prolonged oligohydramnios, we rule out the pulmonary hypoplasia. If any history of the tachycardia, then we might rule out the hypoxia and acidosis. Any pre-antenatal medication which prematurely close the PD, ductus arteriosus might end up with the PPHN. So there's a lots of antenatal history which we can rule out the chronic cause and the acute cause. So till now, as per your history, it might be the acute event at a time of delivery because of the meconium aspirate and the baby is not cried well. So there might be acute vasoconstriction of the pulmonary vessels. Yeah?
yes.
Go ahead.
Now, sir, brief examination on admission. Head to toe, baby was intubated, anterior fontanelle at level, caput succeedum was present, and staining of meconium cord. On respiratory examination, bilateral air entry equal, subcostal intercostal retraction was present, and Downey score at admission was 8/10. Cardiovascular, S1, S2 was normal, no murmur, and abdominal examination, soft bowel sound present. On CNS examination, posturing of bilateral upper limb and Thompson score at admission was 8/15.
Satyendra, what
Yes.
what is the Thompson score first of all, because it's a new parameter. No, not new, but generally we routinely assess the Sernat scoring for the HIE. Am I right?
Yes,
So how it helpful to manage this suspected HIE baby?
yes, sir. It's predominantly is tell about the perinatal asphyxia, and it's sensitive is almost 95%, and it's did not include the EEG parameter. It's mainly for the staging for maximum score, minimum score, normal score was 0, maximum score is 22, and there is if there is 0 to 10 then is mild, and 10 to 15 then moderate, and more than 15 is severe Thompson score.
Yeah, so rightly said by the Satyendra that basically it is useful to give the prognosis of the HI baby. So there's a maximum score would be 22, and if it is like more than 10, there might be the possibility of the poor neurological outcome in point of HIE, and the sensitivity would be 71%, so it would be slightly less, but
Right.
specificity is 96% on this
96.
baby. Yeah, so it is helpful for the prognosis of the. Yeah, go ahead a second.
Yes. Now the hospital course, now in first 24 hours, baby was kept on mechanical ventilator, SIPPV mode, pressure control mode, FiO2 was 100, P was 6, PIP 16, TI is 0.35 second. UVC was taken, not able to put UAC, and blood investigation was sent, and IV fluid with calcium and injection for phenobarbital was started. And there is first we had 3 hours of life, which was PS 7.15, PCO2 is 36, PO2 25, bicarb 12.5, and lactate 11.7, which shows mixed acidosis with hypoxemia. And first blood report was SP was 15.5 gram, TLC is 55,000, platelets 1,76,000, CRP was 66.5. and for which IV antibiotic injection peptide and injection amikacin was started, and first X-ray at 4 hour of life, and is X-ray showing there is right reticulogranular pattern, and there is cardiomegaly. CT ratio is more than 0.6. The USG cranium done on admission, which was normal, and the structural and functional 2D echo was done, which was so right atrium and right ventricle were dilated, and there is severe pulmonary artery hypertension. So according to clinical and 2D echo finding, injection milrinone was started.
Satyendra, may I ask, like, why you start the milrinone, not the enol nitric oxide in this baby? Am I audible?
Yeah, Vishal bhai. Vishal bhai, you are audible, but I think his screen has got hanged.
Sorry, that's fine.
Yeah. Satyendra.
So his Zoom exited. He's trying to rejoin.
So till now we just reached to the ventilation part, and according to Satyendra, finding baby have a PPH and persistent pulmonary hypertension, as we can see the right to left something on the PDA, and right ventricle and the RA is dilated. So there might be the poor function of the right ventricle, and that is the might be the cause that they started the milrinone. And we know the milrinone action, it basically act on the phosphodiesterase 5 enzyme, which ultimately increases cyclic AMP, and which is a potent vasodilator. So that's why is a drug of choice in this case. But according to the history, we can know that this baby has an acute event during the delivery, and if we go in the detail of the pulmonary vasculature, there might be the mild addiction of the pulmonary vasculature, and most of the time we are getting this kind of baby like meconitis syndrome, hypoxic baby, acidosis, and they are well respond with the pulmonary vasodilator like enol nitric oxide, sildenafil, and the milrinone. But we have to make sure that when we start the milrinone, the blood pressure should be up to the mark. Otherwise, it decrease the systemic vascular resistance, and we might end up with the hypotension. Dipen bhai, can I give more information, new thing regarding the PPH until Satyendra join?
I think his computer has hanged, so he will mail me and I will upload his screen. So then that's where we will coordinate.
Long-standing dyslexia.
Hello.
Hello. Yeah, Dr. Dhiren.
Hello. Am I audible?
Yes.
Yes, yes, audible. I have shared the screen now. Satyendra,
Yes, sir.
now I will go to the slides, right? You will
Yes,
speak.
sir. Yes.
So now I think where you were here.
We are the
It was up to the X-ray.
Milidon.
Milrinone and X-ray portion.
Yeah.
I think the slides are clear, right?
Yes.
Okay.
I think that, yeah, he was here.
Yeah. Yeah, Satyendra, go ahead.
Sir करेंगे तेरा अच्छी.
Satyendra, आप बोलो next, so I will go to next slide. Okay. Satyendra,
जी sir.
Sir, change करेंगे.
you please speak. I will change the slide. आप बोलो next, तो मैं next
Okay.
slide पे जाऊंगा.
Now the USG cranium done within 6 hours, which was normal. Structural and functional 2D echo were done, which was showing large patent ductus arteriosus. Shunting is bidirectional, and right atrium and right ventricle were dilated. There is severe pulmonary hypertension. So according to clinical and 2D echo finding, injection milrinone was started. And the hospital course in first 24 hours, at 6 hours of life, baby was desaturating on SIPPU mode. His baby was shifted on high frequency oscillator ventilatory mode. P mean was 16, amplitude was 32, frequency was 10 Hertz, and IE ratio was 1:1. FiO2 was 100%. In spite of starting injection milrinone, there was persistent severe PH, so injection sildenafil was added. Now, at 12 hours of life, ABG was PS7 1.27, PoCO2 is 35, bicarbonate is 17.3, base axis is minus 9.8, PO2 was 155 and lactate was 9, OI was 10. And chest X-ray at 24 hours of life, there is some improvement in both sides of the lung. At 24 to 72 hours of admission, in view of scleroderma and edema and decreased urine output, 0.5 ml per kg per hour, blood reports, sepsis screen, serum creatinine and electrolyte were sent, and CRP increased from 66.7 to 112.5. So antibiotic were upgraded to injection cefaperazone sulbactam and injection linezolid. In view of hypotension, the mean BP was 32 along with clinical parameter. Injection noradrenaline was started. The serum creatinine value was 2.78. So injection amikacin was stopped and injection dopamine in renal dose was started. USG abdomen and pelvis, which was normal, and fluid challenge was given, but there is no increase in urine output.
Yeah,
So-
Satyendra, can I just interrupt in between? Can you just go to the previous slide?
Yes.
And just go one back. So there was a scleroderma edema and the urine output had decreased.
Yes.
So you had done the echo earlier also. So at that point of time, what was the condition of the IVC? I mean the inferior vena cava, because when you do a functional echo, you just not only look at the heart, but basically you also look at the IVC, because that will also give you an idea regarding what was the fluid status of the body. So was there any comment made on the 2D echo at that point of time? Whether the IVC was full, tense,
No,
it was distended, dilated, any movement with the respiration, etc., etc.
So there IVC was collapsible
Collapsible at that point of time. So this
Yes,
was the
sir.
echo which was done after 6 hours of the birth.
after
Okay.
6 hours.
Okay. And did you do any repeat echo after 20? Because this is the condition now at 72 hours of the admission. So almost on the third day, and the patient has started developing edema as well. So did you do any echo at this point of time?
We did, sir, at 2 days of 48 hours of life after that.
So what was the echo finding at the 48 hours of life? Have you mentioned? Will it come in the
Yes, sir. Sir,
subsequent
I
slides?
mentioned in next
Okay.
slide.
Okay, fine. Secondly, that now at this point of time, since you have mentioned that the urine output is 0.5 ml per kg per hour.
Yes,
So what are the parameters which you are looking forward at this point of time to say that the patient has developed some sort of renal injury?
yes, sir. First, there is urine output,
Yes.
and then, sir, there may be dehydration and fluid overload.
Okay.
And in clinical parameter, and in blood reports, so there is increase of serum creatinine value.
Okay.
And
So yeah. Go
Yes.
ahead. Go ahead.
in
Go ahead.
differentiate pre-renal to renal, we will do urinary indices like FINA and renal failure
Yeah, that is
index.
true. That is true.
Yeah.
Now it is basically all textbook picture, because you now have echo in your hand. So you can immediately
Yes, sir.
say whether it's a renal or renal, that's fine. So let's be more practical. At this point of time, I mean, like you said that the urine output is less, and you also seen the creatinine values here. So
Yes.
have you heard about the KDIGO guidelines where you can stage the kidneys
Yes, sir.
as far as the AKI is concerned?
Yes,
So
sir.
yeah, so at this point of time, with your urine output 0.5 ml per kg per hour, or your creatinine at 2.68, which stage of KDIGO, I mean the numerical KDIGO guideline, which stage of the renal injury is this?
Yeah, this is stage 2 of renal injury. According to urine output, there is decrease of 0.5 ml per kg per hour in last 24 hours.
No, that is fine, because as far as the AKI is concerned and as far as the staging is concerned, you have a creatinine values as well as you have a
And
urine
the
output.
urine output. value.
Yeah, so this
What was the
basically
baseline creatinine? Basically, he's asking.
absolutely.
The baseline creatinine was 2.7.
So that is the first creatinine which you have done
First
at this point
creatinine.
of time.
Yes, sir. Yes,
Okay.
sir.
Fine, absolutely fine, not a problem. What I'm telling you or asking you is that in the KDIGO guideline, you have two parameters. You look at
Yes,
the
sir.
creatinine values, and nowadays we have also taken into consideration the urine output. The
Yes.
urine output is taken into consideration from the point of view that many a times the creatinine takes time to rise. Okay.
Yes, sir.
Only when 50% of your glomeruli are damaged, or in other words, when your GFR falls to below 50%, the creatinine starts rising. So sometimes it may happen that even though the acute kidney injury has set in, the creatinine may start rising after 12 to 24 hours. So at that point of time, your main parameter becomes the urine output. But on the contrary, sometimes the creatinine starts rising and you have a non-oliguric renal failure as well. Okay. So that's why we have to take into considerations both the factors, that is the creatinine as well as the urine output. And the staging is done whichever is poorer. Okay. So whatever is worse, the staging is done on that. So again, you have a urine output of 0.5 ml per kg per hour. You have not mentioned since how long it is 0.5 ml per kg per hour, since 6 hours, 12 hours, 24 hours. Okay, so I guess that maybe it is around 12, 24 hours or 12 hours, and it is
So
stage
last
2.
12 hours.
12 hours. Okay, so it becomes stage 2. But if you look at the creatinine values, it is 2.7. So what is the creatinine value in stage 3?
So it's more than 2.5.
Exactly. So this basically we have to consider as a stage 3 AKI.
3.
Okay. Okay. Now, again, coming to the hypotension. So you said, Dr. Goyal sir also mentioned that milrinone is a double-edged sword sort of thing because it decreases the systemic vascular resistance. So sometimes you might end up with a severe fall in your blood pressures, especially the diastolic BP. And your kidney injury is very much related to your kidney perfusion, which is in tune to the diastolic blood pressures. So many a times we are quite contented in our, even in the NICUs where I go, people are very much contented that the BP is okay. But when I see the BPs, the systolic BP is okay, but the diastolic BP is just 20, 10, 15. And your mean goes below 20, 25. So your kidney perfusion is highly hampered at that point of time. So it is very, very imperative that you look at both the parameters, not only the systolic BP, but the diastolic BP as well. And the mean BP has to be targeted about 35 to 40 millimeters of mercury so that you can have an adequate renal perfusion to prevent the renal injury. So you are absolutely right in starting a NORAD at this point of times because you want to raise your diastolic BP as well as your mean arterial pressures. Okay, go to the next slide. Now here you have told that you have given a fluid challenge, but there is no increase in the urine output. So just tell me, are you warranted in giving a fluid challenge at this point of time when you have a child who is having a decreased urine output less than 0.5 ml per kg per hour, who is edematous, whose creatinine is 2.7 at this point of time? Because we are always taught in our previous, few years back, that whenever there is no urine output, you give fluid challenge, you give Lasix and C. But nowadays, what we want is less is more. So we want less. So now the the critical care is shifting from loading the fluids to deloading from fluids. So it is very, very important that we don't load it, because I'll just come to it later on, that what is the importance of the fluid overload in managing the patients with the AKI and what correlation does it have with the mortality in the ICUs. Okay, the fluid overload. So already the patient is overloaded, and I don't know the echo, you will show it in the next slide probably. But if your echo at that point of time, before giving fluid challenge, what I would like to do here is that I would like to look at your echo. And if your echo is showing a IVC which is full, an IVC which is tense, and the patient is already loaded, there is no point in giving any fluid challenge at that point of time to see whether the child is having a good urine output or not, unless and until the child is clinically dehydrated or your IVC is collapsible. Okay.
Yes, sir.
Okay, you can go ahead. Okay, just one more point. What was the point in starting dopamine in this patient?
Yeah, just I am about to ask that is there any role, like studies showing that there's no any role if you start at less than 5 microgram per kg per hour or whatever.
No, that is
So-
fine. But that is fine. But what is the role of pharmacotherapy in AKI? The question lies, is pharmacotherapy in AKI? So which are the drugs which you commonly use for the patients with AKI? Which drugs you commonly use in AKI? First of all, dopamine you already mentioned. Is there anything else which you use so that you can get a good urine output?
If AKI is due to birth asphyxia and perinatal asphyxia, then
Yes.
injection theophylline was also given.
No, Awaken study has told that theophylline
5
doesn't
to
have much
8
role.
milligram per kg.
Yeah, but the Awaken studies have told that the theophylline has no role.
And
Even many
second
of the
drug was
cardiacs.
furosemide after fluid challenge.
Okay, furosemide. Then is there any other drug? Have you heard about phenaldopam?
Yeah.
Yeah, what is that? It is a D2 receptor agonist.
No.
But can you tell me in a nutshell that what is the role of pharmacotherapy in AKI? Whatever drugs you are giving, dopamine, Lasix, phenaldopam, all these drugs are just to increase your urine output. But is there any else which any other role of your pharmacotherapy in AKI? From your neonatal perspective, I'm not talking about the adult perspective. From the neonatal perspective, what is the role of pharmacotherapy in AKI? You get my point?
Yeah, we can stop the nephrotoxic drug and adjust it dose according to the GFR.
Yeah, that all is fine. But the pharmacotherapy for the treatment or for the management of the AKI. So basically, the common drugs which we use are dopamine, your furosemide, or your phenoldiazepam. So basically, all these drugs are used to increase the perfusion of the kidneys and increase the urine output. But remember that none of these drugs are going to alter the long-term outcome of the patients in the AKI. Neither of them are going to cause your improvement in your GFR. Okay. So all these drugs are just to convert an oliguric renal failure into a non-oliguric renal failure. So from a nephrologic perspective, if you take into consideration some older children or adults, I will not start any of these medications in them. But considering the neonatal platform in which we definitely want to convert a oliguric into a non-oliguric renal failure from two important points. Number one, we can abate the need of renal replacement therapy. Of course, starting this pharmacotherapy doesn't mean that you can obviate the need of renal replacement therapy, but the condition is different in neonates, especially when you are catering to some very small neonates, 1.2 kg, 1.5 kgs. It becomes very, very difficult and messy to do a peritoneal dialysis or to dialyze those children. So at that point of time, you need to create the space to give your fluids, your nutrition, your antibiotics, your blood products, etc. So that's why we need to convert an oliguric renal failure into a non-oliguric renal failure. And hence it is imperative that in these patients, we are justified in using all these medications. But otherwise, if you're using it to prevent the AKI or to convert an AKI into, or to, or in other words, to improve your creatinine values, this have no role whatsoever as far as the improvement in your GFR is concerned. But definitely one drug has shown a promise. Can you tell me that drug, the name of the drug?
Sorry, sir.
Okay, so one drug which has shown promise in the AWAKEN study is your caffeine. And in fact, it has been shown in the AWAKEN study that it reduces the odds of developing a AKI. So in fact, the studies have shown, the AWAKEN study has shown that it, when used in 4 patients, it prevented 1 AKI. So it prevented 25% of the AKI. So I think so, especially in the patients who are having an hypoxic ischemic renal injury, as in this case, the role of caffeine definitely holds a value, but still it has not been studied extensively in the neonatal AKI, and therefore we don't have much of the results. It is just a, what we say, byproduct of some of the studies. Okay. So this is just to carry the message to all the residents who must be watching over here, that pharmacotherapy doesn't cause any sort of improvement in your AKI, neither does it improve your renal functions. It is definitely used to convert your oliguric into non-oliguric renal failure for the reasons which I have narrated. Okay, you can go ahead.
And on repeated 2D echo, there is decrease in pulmonary pressure and less than 5% O2 saturation difference in pre-ductal and post-ductal. Both milrinone and sildenafil were tapered and stopped. And gavage feeding was started at 5 cc EBM every 3 hours. Now, the day 4th of admission, in view of decreased urine output, repeat RFT were done, which show there is increase of serum creatinine value 3.5 milligram, for which pediatric nephrologist opinion was taken as per advice. Total fluid was restricted and injection Lasix infusion was started. Day 5th of admission, after 12 hours of injection Lasix infusion, urine output was 0.3 ml per kg per hour. So ABG along with RFT was sent. ABG showed severe metabolic acidosis, for which injection soda bicarbonate correction was given, and RFT report shows serum urea was 101 and serum creatinine was 4.2, sodium was 124 and potassium was 3, for which peritoneal dialysis was started and continued for 2 days.
Can I interrupt here, Sir Satyendra?
Yes, sir.
Yeah, can you go one slide back? So this was the 5th day of admission.
Yes, sir.
So can you give a calculation of how much amount of fluid was given between 3rd day to 5th day of admission? Number 1. And what was the urine output, or other words, we can say what was the total output considering the insensible loss plus urine output from 3rd to 4th day of admission? Do you have any record of that?
Sir, we restrict the fluid up to insensible water loss plus urine output replacement.
No, that is fine. But
Yes, sir.
but can you just tell me that what was amount of fluid which was given? I mean, have you any calculation for that or not? If you don't have it, it is fine. Not a problem.
No, sir.
Okay. So
According
here
to-
comes the catch here. In
Yes, sir.
all the patients having an AKI, especially a stage 3 AKI, it is very, very important that you have a hour to hour at least urine output monitoring. In the NICUs, which normally we work, the urine output is calculated on an hourly basis over here. And the fluid input is also calculated on an hourly basis. So it is very, very important that you match the input output chart on an hourly basis so that you can always try to restrict the fluid and you don't overload it. Okay. Number two is that was it possible for you to weigh this child? Because I can understand the child was on ventilator, high frequency, so it might not have been possible. But did you weigh the child by any means?
No,
Daily
because-
weighing was possible?
No, sir, because child was in high
Okay.
flow oxygenated
Yeah, yeah.
ventilation.
Okay, agreed. So clinically, did you feel that the child was gaining weight at this point of time from day 3 to day 5?
Yes, sir. There are edema, development of edema.
The edema was worsening. And did you
Yes,
do
sir.
any sort of a functional echo at this point of time between day 3 and day 5?
We do 2D functional echo to see the
No, no.
status of, yeah.
Yeah. So, yeah. So did you do between just day 3 to day 5? Did you do it or not?
Yes, sir, we will do it.
No. Okay, that's fine. You do it. But have you done or not in this patient? Was it done? Do you have the
Yes, sir.
report? I mean, if it was done.
Yes, sir. To see the pulmonary hypertension and IVC diameter.
Yeah. So what was the IVC like in this patient between day 3 and day 5? Did it worsen
IVC
from day 3 to day 5?
Yes, sir. It's worsened from day 3 to day 5.
Okay. So that means that your fluid overload had been worsening.
Yes,
So one
sir.
of the most important factors which we take into consideration in the management of the patients with an AKI, or in other words, one of the most important factor to tell you the outcome or to modify the outcome in the patients are having AKI is the fluid overload. Okay, the fluid overload index. And the fluid overload index is very, very important because the moment your fluid overload goes beyond 5%, the chances of your mortality and morbidity increases. About 10%, the mortality is about 60%, and above 15% of your fluid overload, the mortality is a tune of about 70 to 75%. Okay, you get me?
Yes.
So in fact, studies have shown that just 1% increase in the fluid overload increases the odds of mortality by 6%. You understand? So
Okay.
just little bit increase in your fluid overload can lead to your high chances of mortality in the patients who are having an AKI. So that is what we don't want here. So was it not prudent that if you are having a urine output of around 0.3, 0.5 kg per hour for about next 12 to 24 hours, should we have started a renal replacement therapy slightly earlier in this patient instead of relying on the Lasix infusion? Because if the kidneys have been responsive, your Lasix will start acting immediately within 2 to 4 hours. You will start developing a good urine output. Okay.
Yes.
Yeah. So basically, this patient at third day of life, when you have an edema, when your patient is not responding to your fluid challenge and the Lasix bolus, and if your child is having an IVC which is dilated, and if you are having a urine output of 0.5 ml per kg per hour, which is also gradually decreasing, it becomes little bit what we say difficult measure to continue with your fluid restriction and the Lasix infusion till the 5th day of admission, because you have by that time gained a lot of weight in this child. The fluid overload is very, very significant, and that decreases the chances of survival. The mortality rate is becomes very, very high in this patient. Okay. Secondly, your sodium is 124. Will you treat this sodium?
No, sir.
Why?
Because, sir, this is dilutional hyponatremia.
So what will you do to treat this sodium?
Sir, we restrict the fluid.
No. You have to dialyze. There is no other way out.
Dialysis.
Yeah, basically. So what are the parameters in which you will start your dialysis? Forget about this patient. What are the clinical indications of dialysis
First,
or indications for dialysis to be on a broader perspective?
there is persistent hyperkalemia.
Okay.
Second is, sir, is severe metabolic acidosis, which not managed by medical management.
Okay.
Third, sir, anuria for last 24 hours.
Okay.
sir, if there is need of calorie, which
Okay, very good.
we
Yes,
cannot fulfill by fluid restriction.
absolutely. Yes,
And
very good.
and any sign of uremic encephalopathy
Yes, absolutely right.
and
Okay. Okay. So to be more precise, or for our what we say, um, academic part, we can divide it into two components. One is basically your clinical component or your clinical indications, and one is your biochemical indications. So what are the clinical indications? As you mentioned, the child is having a severe fluid overload or a pulmonary edema, or you require space for your calories and also for your fluids, or the patient is having a severe uremia, bleeding, or uremic encephalopathy. Okay. And as you mentioned in your other component is your biochemical component, like your severe dyselectrolytemias, hyperkalemias, or your severe metabolic acidosis. So all these are your components of your biochemical portion. But remember, there is no single value at which you can say that you can start the dialysis right now. The moment you feel that the child is not good, you have to start your dialysis. It is just like your ventilation. Do your ventilation. If the child is good, you can remove from ventilator within 24 hours, and same is for dialysis. So it should be your gut feeling to start the dialysis, and it should not wait for your parameters to come up or down. So you can't wait for a creatinine of 3 to start dialysis or a 4 to start dialysis. If you feel the child is having severe pulmonary edema, even though the creatinine is 1, you have to start your dialysis even at that point of time. Okay. Fine, you can go ahead. Yeah.
yes. Now, 6th day of admission, peritoneal dialysis was started and continued for 2 days. Baby was maintaining blood pressure and hemodynamically improved. Injection noradrenaline was tapered accordingly and stopped. There was one episode of cyclical movement of lower limb with desaturation and bradycardia. Injection leveracetam was loaded and continue in maintenance dose. Now, the day 8th of admission, in view of deranged coagulation profile, INR was 2.1, 1 unit of FFP was transfused. As there is increased urine output, 2.4 ml per kg per hour, peritoneal dialysis was stopped, and post-dialysis sample showed urea is 49 and serum creatinine was 2.3. The sodium was 138 and potassium was 3.8 milliequivalent per deciliter. Now, day 8th of admission, baby maintaining saturation on minimum ventilatory setting of high frequency oscillator. P mean was 10, MAP was 20, and FiO2 was 30%. So, along with clinical improvement of baby and ABG showed pH was ABG, which was normal. pH was 7.42, PCO2 was 38, and bicarb was 24.9. PO2 was 64, lactate 1.8. Baby was 52 SIME mode of ventilator. It's a day 8 and the X-ray of day 8 of admission. There is improvement in the right side as well as left side. Now the 9 to 12 day of admission, there was repeated sepsis skin was sent, which showed improvement. CRP decreased to 15.6 and blood culture was sterile. Hence antibiotic was stopped. In view of low serum potassium level, serum potassium chloride oral suspension was started, and gradually OG feeding was increased as tolerating well. At 12 to 15 day of admission, baby was maintaining saturation above 95% and vital was within normal limit or minimum setting of SIMV mode. The ventilator, so baby was extubated and keep on nasal CPAP with P5 and FiO2 30%. As baby had no.
Sorry to interrupt, Satendra. So
Yes,
in case of the PPHN, what would be your target saturation, and how will you see the ABGA when you manage the PPHN case?
Our target saturation was 90 to 95%, and PaO2 was 60 to 80. In
60
blood
to 80.
gas.
So blood gas. But when you like, I see the previous gas, the PO2 was 133. So it is
133.
all right. Yeah, and the PCO2 is 35. So it does it ideal, or it is like you need to change the ventilation setting, or you need to change something?
No, sir, this is not ideal. This you
Okay,
can
so what would be the ideal thing? Like, so uh, how much PO2 you like to maintain when you treat the PPH, and what would be the PCO2, PaCO2 level when you
the
manage the
ideal
PPH
PCO2
baby?
PO2 level was 60 and PCO2 level was in between 35 to 45 or permissive hypercapnia.
Yeah. So, so rightly say by the Satyendra. So nowadays we have to like in previous day people are doing alkalosis like over ventilate the baby to treat the PPHL. But nowadays, in your case particularly, it is useful to maintain the PCO near to the 60 because baby has had a hypoxic event during the delivery, and when you have a low PaCO2 in your body, ultimately there is a vasoconstriction of the blood vessel in the brain, and there is a less blood supply in the brain, which is already hypoxic. So, so any baby who has a hypoxic event and with the PPHN, we have to maintain the PCO2 level around nearly 60. And nowadays, the target value of the SpO2 would be between 93 to 97 because research are suggesting that if you maintain more than 98%, there would be hyperoxia. And most of now tertiary center are getting the nitric oxide resistant PPHN cases. And if you do a more hyperoxia, ultimately it creates the free radical injury, especially superoxide dismutase, and which inactivated the phosphodiesterase 5 enzyme, ultimately decrease the production of the nitric oxide. So it is really helpful to maintain the SpO2 93 to 97%, PaO2 50 to 80, and pH should be more than 7.25.
Yes.
Yeah, go ahead, Satyendra. Yeah.
On 16 to 20 day of admission of CPAP trial was given, which was tolerated well. Baby was kept on minimum oxygen support and MRI brain was done, which show abnormal T1 hyperintense signal intensity, C along globus pallidi as well as along periventricular white matter body of right lateral ventricle, suggests possibility of hypoxic injury. Now, the 21st day of life, ROP was done, which show immature retinal vasculature. Repeated USG cranium was also normal. Katori spoon feeding trial was given and as tolerated well. After that, breastfeeding was tried and continued. Off oxygen trial was given, which was tolerated well, so oxygen support was withdrawn. These are sequential ABGs. Initially, we did every 12 hours, then in 1 ABG in 24 hours, and yeah, 2 ABG in 12, then 13, 14, 15. There is improvement in 13, and there is fall of PS in again in 16. Then at 19, there is also 18 and 19, there is increase of pH and PCO and ABG parameters.
So that is probably because I think so on 6th or 7th you started your peritoneal dialysis.
Peritoneal dialysis, yes.
Yeah, so this bicap was possibly because of your renal injury.
Renal injury.
Okay, the acidosis was because of the renal injury, yeah.
Mhm. And the next, these are the blood investigation. According, there is the increase of CRP 112, we shifted applied antibiotic care, and there is normal, and urea creatinine according to days, and on 23rd there is creatinine was 0.43 and there is almost normal. These are APTT, PT-APTT and serum bilirubin values and total proteins value, albumin and globulin. AG ratio was 0.81. Now the general examination. I had examined the baby today with proper aseptic condition and with consent of mother on 25th day of life. Baby is a So previous slide, baby your mother's lap and saturation probe attached to right hand. Next, the vital parameter at the time of examination was temperature was 36.8 degrees Celsius, heart rate 140 unit, peripheral and central pulse were well palpable, CRT was 2 seconds, BP right upper limb 58/40, mean was 46, right lower limb 60/44, mean by 49. Respiratory rate was 56 per minute, SpO2 94 on right upper limb and 96 on left lower limb. There is no pallor, icterus, sinuses, and edema. Now the anthropometry admission, there are weight 2.73 and expected 2.8 in between 10th and 25th percentile, and was 48 and expected 51, which is on 58th percentile. Hair circumference was 34 and expected was 34, which was 58th and 58th percentile. These are plot on the growth chart. Of the head to toe examination, there is no swelling overhead. Anterior fontanelle was to open at level. Posterior fontanelle just tip of finger administrated. No facial dysmorphism. Head reflex bilateral normal. Ear normal in size, shape, and position. There are no cleft palate, no cleft lip. There are no any birthmark or injury. No septum, alley, bridge appear normal. Neck, there is no swelling over the neck. No polydactyly or syndactyly, back and spine was normal, and an opening present and patent, genital was normal, and bilateral hip examination was normal. On the systemic examination, I had examined when the baby was not crying and spontaneous movement of all 4 limbs were present, presentable stage 4, and in motor exam, higher mental function, conceptuality and credibility was not assessed, normal posture, bilateral upper limb in flexion and lower limb slight abduction. The tone, active tone, pull to seat, vertical suspension, horizontal suspension, not assessed. Passive tone, scarf sign, hand code, does not cross the midline. Popliteal angle was 120 degree, heel to ear maneuver, not touch the ear. Power was more than 3/5 in all 4 limbs. So cranial examination was also normal. Cranial nerve was not assessed. Cranial nerve to pupil bilateral reacting to light. 3, 4th and 6th ocular movement symmetrical and no sequent. Cranial 5 rooting and sucking present. Cranial 7 no facial asymmetry. Cranial 8 starlet reflex present. Cranial nerve 9 and 10 sucking reflex present. 11 normal head and neck movement. And 12 no deviation or fluctuation of tongue. Now the bilateral knee jerk was normal. Bilateral plantar reflexes were flexion of great toe with extension and fanning out of other toes. And all primitive neonatal reflexes, palmar and plantar were present, starlet reflexes were present, rooting and sucking reflex were present. Morose asymmetric toe reflex was not assessed. Now, the respiratory system examination, there are no nasal deviation or block, no pulling of secretion, bilateral symmetrical chest rise, there is no entry, air entry bilateral equal and clear, there is no sign of respiratory distress. And cardiovascular examination, precordium was normal, apex impulse located 4th intercostal space, medial to the mid clavicular line, 1st and 2nd heart sound present, no murmur, heart down auscultation. For abdominal examination, inspection, distended but soft, the skin over the abdomen looks normal, there are no visible bowel loop, no visible pulsation, scar or vein. The palpation, superficial palpation, there are no tenderness. The deep palpation, liver was 1 centimeter palpable and spleen not palpable. Auscultation, bowel sound was heard. Genital was normal. On baby discharged on 8th day and 26th day, 8th May, 26th day of life after explaining all the danger. Routine follow-up after 2 days on discharge weight 2.773 and head segment was 3.4. 34 and length was 48 centimeters. The summary, 20 days old female born to second gravida mother, delivered at full term 39.5 weeks by normal vaginal delivery. The birth weight was 2.91 and AGA with birth asphyxia, HI grade 2 with meconium aspiration syndrome requiring high frequency oscillator ventilation, severe PPHN and acute kidney injury stage 3 requiring peritoneal dialysis and multi-organ dysfunction syndrome. which involve kidney, cardiac, hematological system, and the deranged population profile requiring FFP. And with probable sepsis.
Satendra,
Yes.
you rightly mentioned the diagnosis, and you just mentioned that baby has HI grade 2.
Yes.
Am I right? So,
Yes.
what do you think about? Do you want to consider the cooling in this case, or what do you think?
Sir, there mostly, sir, babies in favor of, but there are severe PPHN. So severe PPHN is relative contraindication of cooling. Otherwise, all the parameters are in favor of cooling. So we consider this child in severe PPHN. So
But
that is
do you think we can offer the cooling with the PPHN because it is the only relative contraindication?
yes, sir. This is relative contraindication, not absolute contraindication, sir.
The
And
only contraindication for cooling is mostly the derange, the coagulation,
there is population profile and sir, major congenital malformation and sir, major chromosomal anomalies like trisomy 13 and 18.
because when you mentioned the summary HI grade 2, then I'm just talking out of blue that in medical legally, if somebody read this summary and we have to mention to the parents that there is one of the cooling option because currently the moderate has a very good outcome if you offer the cooling. Am I right,
Yes.
Satendra?
So, second point, sir, there is initially pH, ABG pH was 7.15. And
so there is a two criteria
two
for
criteria.
yeah. So but any baby who have, you mentioned that a baby has a posturing because we do not have any EEG. If baby has a EEG and we can mention the convulsion, or either if baby has a posturing, if you're mentioning like that, that means baby already have moderate HI. If you see in the Sarnath staging, in the convulsion appear in the stage means grade 2. Am I right?
Yes, sir.
So that's the thing. So it is like we have to see the things that the message would be the PPHN is not a contraindication for the cooling. That's the key message for now. Okay. Hello, can you hear me?
Yes, sir. Yes, sir.
Yeah. So go ahead, please.
Hello.
Yes, sir.
Yeah.
Yes.
Hello.
Yes, Satyananda. So your case is over now?
Yes, sir.
Yeah.
his
So
case is over.
yeah. Okay. Okay. So since we have been talking regarding this wiki, I think we have almost covered all the portions or all the what we say the aspects of the AKI. Two questions I want to ask you at this point of time. First of all, what are the risk factors for the AKI in a neonate? Because that is the most basic thing which you need to look for. In fact, you need to look for an AKI before the child develops an AKI. Okay.
So common are hypoxia, hypotension, and hypovolemia, sir. Because there are pre-renal AKI is most common. 80% and around 80% in units are pre-renal.
Okay.
And sir, then we ask about perinatal history. And history of maternal drug intake and history of maternal uncontrolled diabetes, and there is history of oligohydramnios.
No, that's an history which will be suggesting. What I say is, what I'm asking you is that what are the risk factors for the AKI in a child or in a neonate?
So,
Risk
like,
factors. Okay.
perinatal
Oligoamnios means already child has a compromised kidney function. Fine.
Okay. So, perinatal asphyxia, respiratory distress,
Okay.
sepsis, and hypovolemia, and so.
Yes. Hypotension. Yes.
And
the point the patient is admitting to your NICU, the risk starts. Okay.
yes.
So the most important risk factor is your NICU itself. The point of time the patient enters your NICU, he's at the risk of developing an AKI. So all your patients who are admitted to your NICU, especially your level 2 or level 3 NICUs, are at the risk. Okay. Apart from that, whatever you mentioned, so that is the most important thing. So you should look at all your patients admitted to your NICU as a potential candidates who might develop an AKI. Okay. So that is basically the most important thing which I wanted to bring it out. So all your patients, even if your child is doing well, he's on feeds, etc., but he's definitely at the risk of ACAR because there are a lot of things which are going on. You have your hypovolemia, hypoxia, hypotension, your ischemia, etc., going on. And the most important thing is the main culprit is your drugs. Do you know that 25% of your drugs which you use in your ICUs, whatever, NICU, PICU, adult ICUs, are nephrotoxic drugs? You know that? 25% of your drugs which you use in your ICU are nephrotoxic drugs. And 40% of your prescriptions, even literature says 40% of your literature of your drugs which are used in the prescriptions in your ICUs are carrying the nephrotoxic medications. Okay. So from this perspective and from this important fact, all your patients who are going to be admitted in your NICUs, especially your level 2 and level 3 NICUs, your risk of your AKI starts, and you should be very, very watchful. And hence, even if your patients are looking good, they're happy-go-lucky patients, you feel that everything is going fine, your patient is simply in your, what we say, your warmer care or your phototherapy care, etc., that patient might go into AKI any point of time because of the factors you already have mentioned out. Okay, so the monitoring of the urine output, because you're not going to look at the creatinine every now and then. The most important parameter here is your urine output monitoring, and not only going below 0.5 ml per kg per hour. If your urine output is 2 ml per kg per hour, and in next 4 to 6 hours, if it falls down to 1 ml or 1.5 ml per kg per hour, you should think, why my urine output is falling? You need to check those, baby, or keep a watch on your urine output most stringently in this patient. Okay.
Yes.
So that is the most important thing. Drugs, as I mentioned you should be very, very careful by using all your nephrotoxic medications, as this patient itself was on 2 nephrotoxic medications, was on piperacillin, tazobactam, and amikacin, despite the fact that the child was having an HIE stage 2 in which you are suspecting an AKI in this patient. Okay. So you have to be very, very careful by selecting drugs. Okay. And number 2 is that as you mentioned, the last creatinine was 0.43. Okay. So is it a happy ending at this point of time?
No, sir.
You feel that everything has been done?
No, sir. We follow this child on regular follow-up.
Yes.
At every visit, we measure the blood pressure of the child.
Okay.
Either in hypertension, then we measure the urine albumin level for watch out microalbuminuria, and also calculate GFR.
Yes.
And
So so that is absolutely fantastic. So you have to monitor all these patients who are neonatal graduates and who has an AKI, because 40% of them might develop a CKD. And the most important thing, apart from your high blood pressures and creatinine values, the most important thing, as you mentioned, is absolutely rightly, is your protein creatinine ratio.
Yes.
That is, you have to look for albuminuria, and that could not be looked by simple urine microscopic examination. You have to go for a urine protein creatinine ratios, because your proteinuria is your harbinger of the renal injury. You don't know how much glomeruli are functioning in your child. Even in this child, you don't know how much glomeruli have survived. And as I told you, the creatinine values will remain normal till your 50% of your glomeruli are damaged. So only when your GFR falls below 50%, your creatinine will start rising. And you don't want that. So these are the candidates who might benefit, or you might retard the proteinuria by use of ACE inhibition. So hence it is very, very important that you check, apart from your creatinine, blood pressures, and your height and weight, etc., you have to look at your proteinuria. I think from my side, that should be the end. And I think we have almost covered each and every aspect or the perspective of your acute kidney injury. If there's any questions or queries, I'm free to take that.
Hello. Yeah, I think from my side also, I think we almost covered the HIV and the PPHN. There's a lot of things in the PPHN we can cover, but I think it is a shortening of the time. But it is a nice presentation by Satyendra. Any questions, any from the audience?
I think only one question asked was, what was the HFO settings? That was asked to Satyendra.
The initial setting was MAP was 25, amplitude was 32, FiO2 was 100%, and IE ratio was 1:1.
Frequency?
Frequency was 10 Hz.
Okay.
I think I thank so much Dr. Deepan and Dr. Prashant Bhai to give the opportunity.
It was actually our pleasure to have you as experts. Can I request Rituparna to present the certificates?
I have already started the screen sharing.
Yeah. So Deepan bhai, please proceed.
Yeah. You can go ahead. Sandra.
We would like to thank Dr. Vishal Goyal for being an expert in neonatal Pathshala. Thank you very much, Dr. Vishal, for
Well,
sharing.
welcome, Dr. Somsekar sir.
मैं
Thank
YouTube
you
पे
so much, sir. Thank you, sir ji.
मैं YouTube पे देख रहा था. I thought I'll thank in person. So
Sir
thank you.
is joining from the universe.
Yes. And Dr. Fagun
The
Shah.
northern light is going a bit behind.
Yeah, so Dr. Fagun Shah has been, I think this is the second or third time that is coming. So thank you very much for coming
Yeah,
to
thank you. It's my pleasure. It's my pleasure.
supporting us for almost now third or fourth year in line. Thank you very much. And thank you, Dr. Satyendra, for presenting.
Thank you, sir. Thank you, sir.
We had a good learning experience, and I'm sure we all will learn from this. Thank you. Good. And thank you, Dipen and Prashant, to ensure that we are doing this on a regular basis with lots of good work that is happening. And just to remind everyone, all of this is available on YouTube. You can go at any point of time and listen to it on a regular basis. Back to you, Prashant.
Yeah, thank you so much. And on behalf of NNF Gujarat, I thank again Dr. Vishal Goyal and Dr. Fagun Shah, as well as Dr. Satyendra Yadav, and the mentor, Dr. Dipen Patel. So on next neonatal Pathshala, we will be having an interesting topic, a rationale of neonatal screening. So you can join by the same ClearNet link as well as the YouTube link. Thank you so much. We can end the meeting. Thank you.
Yeah,
Thank you.
thank
Bye
you
bye.
very much. Thank you,
Thank you.
everybody.
Bye-bye.
Thank you,
Thank
everyone.
you,
Thank you.
Thank you everyone for this wonderful presentation. ClearNet is very proud to be a proud digital partner of this webinar, and we would like to have 2 minutes of yours to present a short video. Please stay with us. I would like to ask sir, please stop sharing your video. Thank you, sir. Please.
I think Dr. Ashwin's audio is on.
बड़ी होती है कि वो हृदय में उतर गया.
Thank you everyone. Thank you everyone for staying with us. We hope we will have you soon after our platform with your next sessions. Till then, everyone stay healthy and happy. We will sign up for today with all your permission. Thank you.
जो खुशी है, आज वाह भाई वाह, देश को एक ऐसा कवि भेंट करने जा रहा है जो निश्चित तौर पे शिखर पे होगा कल. भोपाल के